All right. Good evening, everyone. Can everybody see my screen or see me?
Yes.
Okay, excellent. All right. So thank you, everybody, for coming out. I understand that the majority of people signed on tonight are patients, either former patients of Centeno Schultz, patients of other Regenexx physicians, or just anyone who's interested in the study. Thank you again for taking the time out of your evening to come join me tonight. Hopefully we'll all learn something interesting. All right, so today we're going to talk about our new randomized clinical controlled trial, investigating a treatment for lumbar degenerative disc disease, which is a very formal term for low back pain, essentially, because low back pain encompasses a lot of things. And what's beautiful about a randomized clinical controlled trial is that we get to try something new. The treatment is generally a free option for patients. And, you know, we do it at a facility that's, you know, geared towards this specifically. So a little bit about the facility. We're hosting this study at our headquarters at the Centeno Schultz Clinic here in Broomfield, Colorado. This is the headquarters site for the entire Regenexx network, which is actually a worldwide network of physicians. As you can see in these pictures here, we have a university-grade R&D lab where we've developed protocols and kind of pioneered the way for most orthobiologic treatments. So before we really get into the details of the study, we need to understand a very important concept. What is DDD, or what is degenerative disc disease? Degenerative disc disease really is not just, oh, I have a slipped disc or I have a bulging disc. It's the beginning of the degenerative cascade that leads to the aging of our backs, which is a painful process. So in order to understand what degenerative disc disease is, we have to know what the functional spinal unit. The functional spinal unit is probably the most important concept to understand when it comes to just understanding what back pain is. So the functional spinal unit, we're going to zoom into this little part of the lumbar spine here. And this illustration kind of sums it up beautifully. And so what you'll see is we have a cross-section or a slice of two vertebrae. Okay, so we have a slice here of two vertebrae stacked on top of each other. And you'll notice that there is this little orange box right here that highlights the FSU, not Florida State University, but functional spinal unit. Everything inside this box is what comprises the functional spinal unit. You have the bottom half of one vertebra right here. You have the top half of another vertebra right here. You have the disc in between them that provides the cushion. You have this little hole that is formed here whenever you stack two vertebrae on top of each other. Through this hole is where your spinal nerves pass. And so you'd see like a cross-section of a nerve right here. You have this very important joint right here called a facet joint. Again, you see that this joint is only formed whenever you put two vertebrae on top of each other. And what's not shown here, which maybe I can do in a different color, let's see, orange. What's not shown here are this very important network of ligaments that sort of holds everything together. So you have very powerful ligaments in the back here, what's called the supraspinous and interspinous ligaments. You have a joint capsule, which is basically all kinds of connective tissue that holds these joints together. You have very thick ligaments, very strong ligaments that sort of run down the back of this corridor here, which you can't really see it from this view, but there's like a, if I were to kind of draw an arrow right here, there is a canal running through here where your spinal cord runs. And at the back of that canal are some very thick ligaments. Even on the front of the canal are some very thick ligaments. So very important network of ligaments, which is like duct tape almost, holding bones together. Put all this together, that is called the functional spinal unit. And the reason why we look at all this is because in order to understand what leads to back pain and what leads to degenerative disc disease, you have to know the role that each one of these structures plays.
Do you very much a presentation on backbones?
I'm sorry?
How I'm going to be treated and why and how it works?
Yes, I'm going to get to all that. I have to understand this sort of foundation of anatomy before we can really dive into it. Okay, so here's another sort of rendition of that same figure we were just looking at. This is a cross-section of your spine, looking at it from the side. And you'll notice that it's shaded in 3 different colors. On the left of the screen, you'll see that there's yellow called the anterior column. This is made of the vertebral bodies or the bones and the discs in between. This is what bears the weight of your body. This literally carries the weight of your skeleton and your muscles and all your organs. Then you have this middle and posterior column.
You're nuts already.
I know that, but where is it? Oh, right there. I thought it was on the other.
Hold on.
I've got it.
If everyone could please mute their audio, that'd be great. We'll do questions and Q&A at the end. Thank you.
Thanks, Eric. Yeah, so you have this green and blue sort of column on the right-hand side there. And this part is not supposed to necessarily carry any weight, but it is supposed to facilitate movement, bending, extending, all the, fun little movements we like to do throughout the day. And it houses some very important structures. It houses your spinal cord, which kind of sits right here. This is a really bad looking spinal cord, but the spinal cord sits like so, and it stops right around the top of your back. So it doesn't go all the way down to your tailbone. It stops right around the first lumbar L1 vertebrae. And below which you have this sort of horse's tail of nerves that dangle down all the way down to your tailbone. And at each level, where you see this hole here that we were pointing out earlier, at each level, there is a nerve that exits out from either side. So you have a pair of nerves that exit out from either side at every single level of your spine. Those nerves eventually go down into the buttocks and into the legs, and they innervate the muscles in your legs and some very important structures down there as well. And that's when those nerves get irritated, is your classical sciatica, where you feel that burning, shooting lightning bolt go down your leg. That's what sciatica technically means. So what happens in degenerative disc disease that leads us to have back pain? Well, when you look at this yellow anterior weight-bearing column, you'll see that those discs there are in the middle. Those discs are soft and squishy for the most part. They have kind of a tough outer layer, and then they have a very soft, squishy pulp on the inside. And that enables the disc to sort of squish and side bend and move around so that your spine can bend. But because it's soft, it's not hard like bone and ligament, it is vulnerable. And eventually with time and overuse or injury or dehydration, inflammation, all these things, these discs can start to degenerate, and they start to leak out their contents very slowly, or sometimes very quickly, like an acute herniation. But as that happens, those discs start to lose their height. They get a little bit thinner, and they lose their integrity. So they start to kind of wobble around, and they start to shift and slide. When that happens, you've just suddenly introduced instability into the system. So now the vertebrae are moving in ways that they shouldn't. And when you have instability or abnormal excess movement in your spine, things start to break down and get inflamed. Namely, the joints, like those little facet joints that I had pointed out earlier, these little facet joints right here. The ligaments that hold everything together, they start to wear down and get lax and sort of loose. The nerves themselves can start to get irritated from the chemicals that are produced from inflammation and disc degeneration. And in severe cases, the ligaments can get thick and start to push against the nerves. The discs can really bulge and also start to push against the nerves. And the joints start to become arthritic. And when they become arthritic or inflamed, they start to swell up. And that combination of thick ligaments, swelling joints, and degenerated or bulging discs can cause a lot of pressure and irritation to the nerves. And so that's sort of the snowball that happens that leads us to chronic low back pain. It all starts with that disc sort of getting degenerated. You get some instability, really instability, because a lot of things can lead to instability. All right, so what can this cause? This can cause disc bulges. This can cause arthritis or inflammation and breakdown of the joints. This can cause swelling and irritation of the spinal nerves. We've all probably experienced this at some point. I know I certainly have. So what do we do about it? Well, we have our conventional options, high dose steroid injections like epidurals, which steroids are toxic in many ways to your body. You have nerve blocks and ablations where we actually zap and fry the nerves that provide the sensory information to your back, which have consequences down the road. And then you have surgery. And there's really not much to fill that gap between these kind of simple injections and then an entire surgery. And surgery doesn't always fix the pain. Surgery is really meant to preserve the nerves and the muscles. It may not fix the pain. It may actually even make it worse. So how do we treat this without surgery? Well, allow me to introduce what's called the percutaneous FSU procedure, percutaneous functional spinal unit procedure. This is what we are studying in this randomized controlled trial. This treatment is a non-steroidal, non-surgery PRP or platelet-based injection into all those structures in the functional spinal unit that we were just reviewing earlier. The goal is to introduce stability into the spine. It's not to cure pain or give you a 20-year-old spine again, but it's really meant to promote that stability and give the tissues there, the bones, the ligaments, muscles, and nerves, give them the growth factors and the nutrients that they need to start restoring themselves, to start regenerating. Okay, so how do we do this? Well, we have to treat the entire functional spinal unit, understanding that it can be different for each individual. This is not a one-size-fits-all treatment. This is a tailored, individually specific treatment because everybody's back and their back pain and their back story is a little bit different. So first, we inject, we stabilize the spinal segments. We stabilize each segment by tightening down the ligaments. Those ligaments are those tight duct tape-like bands that sort of hold all the bones together so that when they move in the right direction. We need to tighten those down because if they're loose, things are going to wobble around and move like they shouldn't, and that causes problems. That's instability. Next, we reduce the swelling and the damage that's happened to those facet joints in the back. Those facet joints are the ones that let us side bend and rotate and twist and so on. Then we try to reduce the inflammation and swelling around the nerve roots, those pairs of nerves that exit on either side that go into the legs. We try to reduce the inflammation and swelling around them, giving them a chance to heal. And then we try to help the muscles, those deep stabilizing muscles of the spine. We try to help them grow again. It's interesting to think about, but in the spine, think of it as like a 22-cylinder engine. And each cylinder has some, cams, it has valves, and it has a piston. The spine is a lot like that. Every segment has essential parts in it that need to be functioning at, its optimal performance in order for everything, the whole engine to work well. And so you have muscles, you have nerves, you have ligaments, you have joints, and you have discs. All those components, we need to optimize those. And that's what we're trying to do through this type of, or this type of injections. Okay, so to really reiterate, can we prevent the need for a low back fusion? That's the whole goal of this procedure, to reintroduce stability so that you don't need to have surgery in the near future or at all if possible. Okay, so what do we inject? So we inject around the ligaments, we inject a mixture of what's called platelet lysate and prolotherapy. What is that? Platelet lysate is when we take your a blood draw from an IV, as if you're donating blood. We extract the platelets. The platelets are these little clotting factors that are loaded with proteins and growth factors and cell signaling molecules that sort of orchestrate the healing process. We isolate those platelets. We concentrate them down to a very high concentration, because concentration matters. And then we break open the little platelets and extract all the goodies from the inside, essentially. That's called platelet lysate. We take that and we mix it with essentially a sugar solution, which is geared towards the ligaments. And by injecting them directly into the ligaments, we get those ligaments to sort of tighten down and stabilize. And it gives them the growth factors in order to heal and stay like that. Next, we take what's called high dose PRP and we inject that into the set joints. So PRP is just like the platelet lysate, except we don't break open the platelets. We keep the platelets as is, but we concentrate it to a very high degree. So 14 times the concentration that is normally floating around in your blood. Then we take that same platelet lysate that we had from earlier, and we mix it with a very low dose steroid anti-inflammatory. When I say low dose, it's about 1/1,000,000th of the dose that you would typically find in an orthopedic clinic or a pain management clinic. Because at those very low doses are very similar to the amount of steroid that your body naturally produces. And it's been shown that at the natural dose, it can promote cartilage cell growth. It can promote tendon cell growth or synovial cell, which is like the lining of a joint. So you still get the anti-inflammatory effect without the toxic side effects. We mix that in with the platelet lysate and we inject that around those nerve roots so that those nerve roots can sort of calm down, but it's simultaneously giving them the growth factors to start to heal. Then we take what's called platelet poor plasma. You might ask, why are we using platelet poor plasma? Well, because when we concentrate those platelets, you're left with a lot of fluid or plasma that we previously didn't know what to do with, but now we know that that fluid is actually loaded with anti-inflammatory molecules, growth factors, and specific molecules that stimulate the muscles to regrow. It basically stimulates the growth of muscle stem cells. And so we inject that into the deep stabilizing muscles of the spine in order to promote growth and robustness, I guess, of those muscles. And here are just some fancy ways to describe those things. Something important to note is that these types of injections they have to be done by, number one, a very skilled provider who has to be a physician, MD or DO, graduated from medical school, went to residency and got specialty training, is trained on how to use ultrasound guided injections and fluoroscopic X-ray guided injections. Without those two, it is very unsafe to do these injections. So if you have some, aesthetics, Botox, physician's assistant, something rather saying they can do this, they cannot, or at least they can't safely. So it has to be a specialty trained physician using X-ray and ultrasound guided injections. Somebody always asks me this is an inevitable question. Are we injecting the disc? And the answer is no. Here's why. It's important to understand not all back pain is coming from the disc. There is this sort of momentum of a concept that came about in the last like 40 or 50 years that a slit disc or a bulging disc or a herniated disc is the cause of all your back pain. When in reality, it's rarely the cause of the back pain. It's usually the cause of the degeneration that down the road leads you to back pain. Now, there are some rare instances in which a disc can acutely herniate or bulge or even break open and it's pushed against the nerve or something, and that is called discogenic pain. But it's a very particular presentation. It has a very particular appearance to it that you don't really see all the time. So not all back pain is disc pain necessarily. That doesn't mean the disc isn't implicated, but it's not the main source of the pain. Also, like I mentioned earlier, a degenerated disc is usually the chicken before the egg, or the egg before the chicken, whichever one you choose, but it's usually at the start. Severely degenerated discs that are either collapsed or have herniated to where their contents have spilled out don't respond to PRP injections because either they're so degenerated that you inject something in there and it literally just leaks out. You're better off just doing a precisely guided epidural injection near the disc, and you would probably get the same, if not similar results with a lot less risk. Injecting into a disc is a very risky procedure. The risk of infection of a disc injection is very high, and it's a considerably more painful procedure. So unless there is one of very few specific indications to inject into a disc, there's really no need to inject into the disc. And we don't do that in this procedure for that very reason. Okay, so enough about the procedure itself. Let's talk about the study. How do you get involved in the study? What does the study entail, and how is it structured? So we've been actually doing this procedure for quite some time now and have treated thousands of patients with this procedure with pretty great results. So we figured, you know what, now it's time to immortalize this. Let's start a randomized clinical controlled trial. We have the resources, we have the funds to do so. Let's get this in paper so that we can show the world that this works and we know it does. So a general overview of the study. So it is a single blinded, meaning that the patient is blinded to whether or not it's a treatment or a sham control. It's randomized, meaning that neither you nor I, upon enrolling into the study, know if you're going to get treatment or a sham until the time comes. And it's placebo controlled, meaning a certain proportion of people are getting the actual PRP FSU procedure treatment, and a certain proportion of people are getting essentially a sham injection. And you might be wondering, why would I sign up for this if I'm going to get a sham injection? Hold on to that question. I'll have an answer for you in a second. So in the treatment group, patients who are in the treatment group, they get the platelet or PRP-based injections into the functional spinal unit, just like we had discussed. The dosage is 2 treatments, so 2 separate injections administered 4 weeks apart. I didn't mention this here, but for individuals who are not in the treatment group, who are randomized into the control or sham group, have the option to switch over into the treatment group and get it treated at the 3-month, at the 3-month mark in the study. And I'll talk about that again in a second. So the condition that we're treating, painful lumbar degenerative disc disease, low back pain. If you have back pain, you should inquire about this study. It doesn't matter what kind of back pain you have. If you have back pain, you should inquire about it, because at least, even if you're not a candidate for the study, you could still learn more about your back and why it's hurting. Pre-treatment. So upon screening and getting an appointment, you would meet with a board-certified physician like myself. We would go through an extensive history. I'd do a very extensive physical exam. I would look at your MRIs or your imaging that you may have. And together we would go over the inclusion and exclusion criteria. And if you are a candidate, we would enroll you into the study and set your schedule, your treatment dates, your follow-ups, etc. Your follow-ups, it's a 12-month long study total. So there's a initial appointment, there's procedure number 1, procedure number 2, then there's a 3-month in-person follow-up and a 12-month in-person follow-up with 2 virtual follow-ups in between. So 1 month and 6 month like telephone follow-ups. The crossover option, so like I mentioned earlier, if you enroll into the study and then you get randomized into the control or sham group, at the 3-month follow-up visit, we unblind you, meaning we reveal to you if you are in the treatment or the control group. And if you're in the control group, you then have the option to sort of rewind back to the start and get the actual treatment. And then from there, you would proceed to the schedule with all of the follow-ups. Study completion, it's complete at the 1-year follow-up visit. So if you were in the treatment group, the whole study gets done within 1 year. If you were in the control group and then you decide to switch over to the treatment group, it's 12 months plus the extra 2 months, so 14 months total. Just real briefly, here are some of this is like the simplified version of the inclusion exclusion criteria. If you are a lumbar fusion candidate, if by my assessment, your physical exam and your imaging, or a surgeon has already said so, that you may need surgery, you are automatically a candidate for this study. If you have, this kind of is redundant, if you've had lumbar degenerative disc disease without any prior hardware, like rods, screws, bolts, disc replacements, things like that, if you've already failed physical therapy, you've done conservative treatment, you've seen a therapist, you've seen a chiropractor, you've done all these home exercises, that's also part of the inclusion criteria. You haven't had any prior instrumentation, meaning, like I said earlier, bolts, screws, disc replacements, things like that. If low back pain is the main problem, meaning if your neck pain is the most troublesome thing, and that's really what you're trying to get treated, it's not really going to work for this study. And then lastly, you must not receive any other sort of back pain targeted treatment for the duration of the study, because that can interfere with the results. All right, so again, when you are randomized or when you're enrolled, you're then randomized into either the control or the treatment group. And from there, once you're in the procedure, we use moderate sedation so that you are, number 1, comfortable through the procedure, but number 2, so you're not, aware enough to know if you got the treatment or the sham, because that would sort of bias the results. Again, if you were in the sham group at the 3-month follow-up visit, we revealed to you that you were in the sham group, and then you have the option to cross over into the treatment group. And then lastly, this entire procedure, so the initial appointment, the evaluation, the first and second, and possibly third and fourth treatments are entirely free. The only thing that you as a patient are responsible for is travel. If you need to travel to Broomfield, you would be responsible for the travel and hotel and things like that. And Aaron, if you could put the study website. Our study has a web page where you can go on and do the initial screening. It's called dddstudy.com, DDDstudy.com. Or if you have any questions, you can reach out to our lead research coordinator, Dr. Erin Dodson. This is her email address right here, edodson@regenexx.com. If you have any sort of questions, she'll most likely answer them herself. And if they're medically relevant or whatever, she'll forward them to me and I can answer those questions. So dddstudy.com to sort of go through the screening process and see if you're a candidate or not. All right, so at this point, I want to open up the forum to any sort of questions. I'm going to unmute everyone if I can figure out how to do that. I was able to do it at some point. I think everyone's able to unmute themselves. So I will open up the floor for questions for anyone.
If you had previous treatment in the past, I was at Broomfield in 2021. I had some injections in the lower back. Can I still be a candidate?
So typically, if you've had Regenexx, either platelet-based or bone marrow-based injections in the lumbar spine, technically that's an exclusion. If you had non-platelet or non-blood-based injections, you would still technically be a candidate. So did you have PRP injections? Was that a yes?
Yeah, I had PRP, and then yes, and in the end also bone marrow concentrates, so mesenchymal cells too. So that would exclude me.
So yeah, that would unfortunately be an exclusion. Yeah, because that technically your perception of your understanding of these injections would kind of be different than someone who's naive to it, and so that might alter the results.
Right. Okay. Okay. Thank you.
You're welcome. I think someone wrote a question in here. I'd like to know if the iliocostalis, longissimus spinalis, quadratus laborum, and also the iliolumbar ligaments can also be injected with platelet poor plasma in addition to the multifidus. So the answer is yes. So that is part of my assessment when I do my physical exam. I'm checking all these different muscle groups, these functional spinal groups, to see if they're implicated, meaning, if you have atrophy of the multifidus muscles, does that mean now your long segmental muscles like the iliocostalis and so on are affected? And that means yes. And so we would target those along the margins of the ribs and along the margins of the pelvis. And we certainly do target the multifidus muscles. I assess the degree of atrophy that's present on MRI. And the muscles that have above a certain degree of atrophy, we inject those with platelet poor plasma. Next question is by Kimberly. Is there a specific start date for this process? So we've actually been enrolling for about a year now. And so really the start date is just whenever your schedule permits. If you are local, then obviously that's going to be easier. If not, then it just takes some coordinating in terms of travel on your part. But we are currently enrolling. Next question by Jackie. So if I've had PRP, but it didn't work, am I still disqualified? Well, really the only limitation is if you've had Regenexx, specifically Regenexx, PRP or bone marrow injections into the lumbar spine. If you had an ankle treated or an elbow or a shoulder or something, that's not disqualification. If you've had PRP injections from a different facility or a different clinic or group, that doesn't exclude you either. So it's specifically Regenexx PRP injections. Oh, it was Regenexx into the lumbar spine. So yeah, that would disqualify you from the study. But please, and this goes for the gentleman I was speaking to earlier. I hope you're still online. Just Roger, reach out to me. I can write my email address here. So email me with any questions that you may have, because even if you're not a study candidate, there may be something that we can work out to try and get you treated.
Okay, thank you.
Yeah, you're welcome. All right, any other questions? Vancouver Island. So I was just in Vancouver recently, actually. What a beautiful, beautiful place. We were in Vancouver and then we went to Vancouver Island and saw Victoria. Beautiful place.
Vancouver Island, actually, that's where I live. I'm actually on my boat in Richmond in Vancouver, but I normally live in Duncan, Vancouver Island. and my
Wow.
boyfriend's in Ucluelet, which if you ever have a chance, go to Tofino and Ucluelet. It is beautiful there. The ocean, the waves, the wildlife, the sea life is just absolutely astounding. So I would really
Okay.
recommend
Yeah.
going there next time.
Type that into the chat box. I want to look that up.
Okay, sure.
Okay, so John's asked, I've had PRP shots in the back 3 years ago, which did work for back pain, but it's coming back slowly. So am I not qualified? Again, was that, were those Regenexx injections, or was that PRP done elsewhere?
Done elsewhere.
Done elsewhere. So yeah, if it was done elsewhere, you're still a candidate. And there's some kind of technical reasons why that is. But yeah, if you've had PRP injections and they were done at another non-Regenexx facility, then yeah, it wouldn't disqualify you.
But interestingly, there's a clinic here in Michigan, Macomb Back or Pain Center, and I think I'm going to get the stem cell combination with your the treatment that you are proposing here. I'll pay for it, no problem.
I see. Tell you what, email me because I have some questions about that.
Sure.
And I just don't want to say yes and then you do something that eliminates you from the study, and then so let's talk about that and then kind of come up with a plan that wouldn't exclude you from anything if necessary.
You want a phone number or email?
Well, if you can email me, Aaron just wrote my email in the chat there. Do you know how to access the chat?
I'm doing chat right now.
Oh, okay. Oh, that's right. Yeah. Yeah. Sorry. Yeah. So that's my email address there. Shoot me an email, and we'll figure out a plan.
Okay. Because that'd save me about half. Well, no, about a third.
Okay. Hey, you got to be frugal. We got to pinch pennies these days,
I have a rich uncle. Because it's going to cost about 10 grand.
Woo. Yeah, it's not cheap. That is not cheap. Any other questions?
Actually, if you're part of the study and you're getting your back lumbar treated, is it possible, since you're traveling there anyway, to get other, let's say, I just found out I have osteoarthritis in my toes. Is it possible to get treated elsewhere at the same time, or is that not permitted in the study?
So technically, the way the protocol is written is that it can't be treatments for your back. And that's a little bit of a gray zone because, if you're not getting, just because it's not your back that's getting treated, doesn't mean that it might not be implicated in the back process. So it would have to be like a case-by-case basis to kind of decide, is this going to affect the outcomes or not?
Yeah, they seem to travel all over the body, don't they?
Oh, yes, they do. Everything's connected.
And the body knows where it's needed.
Yeah, precisely. I think Azat Suleimanov, you have a question?
Yes, thanks.
Mhm.
Can you hear me?
Yes, I can hear you just fine.
Yeah. So as I understand, the focus of this procedure is on the ligaments and muscles that support our back.
Mhm.
But are there any improvements, any effects for those people who have bulging discs?
Good question. So again, the only way to answer that would be to simultaneously review your imaging if you have MRIs, and to do a physical exam and take a detailed history from you. Because if you have a bulging disc there, but your pain is not primarily true disc pain, then the FSU or functional spinal unit procedure would be more suitable. Because you can, how do I say this? Bulging discs are almost like wrinkles. Inevitably, we all get some sort of bulging disc. Does that mean that your disc has to be treated? No, not necessarily. And that's kind of one of the points we're trying to illustrate with this procedure, is that while the disc is an important piece in the degenerative process, it doesn't necessarily always have to be treated. And by treating the functional spinal unit and stabilizing everything around it, it gives the disc the best chance to sort of heal itself, which they do heal. Discs do regenerate on their own. It just takes a long time, and they have to have all the supports possible. So the goal really is, by treating the functional spinal unit, that you're enabling the disc to sort of repair.
Mm-hmm. So, so it's should I see it as a secondary effect of this procedure?
Yeah, yeah. The way we measure the outcomes is we have a series of questionnaires that target specific aspects of your life and of your experience with the back pain, how it affects you, how it disables you, what does it stop you from doing, and so on. And we track those things. So it's almost like taking a global look at the outcome. So whether or not the disc specifically is getting better, or everything around the disc is getting better, or whatever, it's, if you are globally improving and you're improving in these specific facets of life, then we know the treatment is working.
Mm-hmm. Okay, thank you.
Yeah, you're welcome. All right, I think Bill is asking a question here. I am scheduled for Regenexx in 30 days, cervical and lumbar. Do you think I should hold and do additional research on your study? Cervical is more of a problem. How is your study different than PRP Regenexx? So that is a very good question. So the treatment for the lumbar spine in the study is the Regenexx PRP treatments we do for the lumbar spine. The only difference is we're trying to prove that it is working by doing this study. And so by doing a study, you have to sort of build all these parameters and limitations around it so that you minimize variables. So if you are already scheduled to do cervical and lumbar, and the cervical is really the most problematic thing for you, I would stick with that plan, because you're going to get, if you're getting your lumbar treated, that you're getting the treatment, the lumbar DDD treatment, the percutaneous FSU procedure. So I would just stick with that, unless, you know, like finances is an issue or something, and you know, you want to just get the lumbar treated, then we could go through the study. But we wouldn't be able to treat the cervical spine while you're enrolled into the study. So if the cervical spine is the main issue, I would probably stick with your plan.
Hey, Jim, this is Bill again.
Yes.
So as a follow-up to that, if I were to do the lumbar first with you, would I still be a candidate if I wanted to go in and treat the cervical afterwards, or both afterwards, if what you are doing in the study did not, you know, give me the relief that I needed?
Sure. Yeah. If you want to enroll into the study, then what that would mean is basically getting your back treated and only doing that in the study for that 12-month period. And then after that, after you've completed the study, then you're free to move about the cabin and do whatever it is you want.
Thanks.
You're welcome.
I was late to the slideshow. Is the slideshow available to download?
Oh, I think so. Yeah, let me figure out how to send that. I think I can do that right here. File menus. I have to close the file. Oh, no, wait, it's doing a direct message. Sorry, hold on. So for some reason, it's only letting me message one person. Oh, here we go. Here we go. Bear with me. And okay, so that should be uploading in just a moment here. Okay, Jackie has a question here. If you need to answer this offline, I understand. I'm scheduled for PRP Regenexx tomorrow on my knees, but with my previous experience with my lumbar, the staff was unable to get enough blood, even though I was well hydrated. I'm afraid this may happen again. Would you know of any solutions for this? Yeah, you're right. This is a question we should probably have offline because there's a lot to unpack and a lot of sort of specific questions to answer. So again, if you want to shoot me an email, I'm happy to hop on the phone and talk with you. And John, I know that you sent me your cell phone as well. I will be sure to. If you could shoot that to me in an email, because I think this chat disappears once we hang up. So shoot me your cell phone number and an email, and we'll have a conversation.
And I can send it to you too. I am taking notes on all of that. So
Okay.
Yeah.
Excellent. Thank you, Erin. That's Dr. Dodson, by the way. Erin, she was our lead research coordinator, and she runs the whole research and development department. It's great.
We could, in fact, just when everybody else is gone, continue the conversation.
Yeah, I mean, I'll probably have to set a time just because we got to wrap things up in about just like a minute or so here.
Right.
So,
But you could wrap it up with everybody else and we could continue.
I have to run too. That's the thing. But if you shoot me an email, we can set up a time to talk.
Okay, I don't see your email. But if your lady there can send me an email, because I gave the information there. Have her take a picture with her phone.
Yeah. All right. I just wrote it back in the.
Oh, you are JG.
Yes.
Oh, that's you.
Yes,
Okay.
James Gaps.
Okay. I'll take a picture.
All right. Okay. So just to kind of wrap things up, it's been a pleasure. I'm glad we were able to have this discussion. I love having Q&A and answering questions about this, because it's like, it's a back pain could be a mystery, but if you take it one by one, you can unravel it and it becomes very clear. But anyways, if you have any other questions, shoot me an email. Everyone that I've spoken to so far, send me your contact info so we can set up a time to talk. Visit the study website, dddstudy.com, and fill out the pre-screening questionnaire to see, just clearly right off the bat if you're a candidate or not. And hopefully I will see you all soon. Have a wonderful night, everybody.
bye. Thank you.
Bye-bye.